All right. So thanks everyone. Good morning. Thank you for joining us this morning. I'm so excited and honored to introduce Dr. Linda Nguyen for her talk today. So Dr. Nguyen, she doesn't need an introduction, well known to us. She's a clinical professor of medicine at Stanford University, and she's a clinic chief in the Digestive Health Center. She completed her med school at UCLA, and she did her GI fellowship training, as she shared, at California Pacific in San Francisco. Her clinical and research interests include GI motility disorders and disorders of gut-brain interaction, with an emphasis on gastroparesis, functional dyspepsia, and chronic abdominal pain. She was a member of NIH, NIDDK Gastroparesis Clinical Research Consortium for many years, and her current research includes identifying biomarkers to better diagnose motility disorders and understanding the role of physiologic testing on clinical care for motility disorder. She is especially interested in developing cross-disciplinary collaborations to expand the role of bioelectric medicine, which is very fascinating in the management of chronic digestive disorders. And she's very passionate about quality of life, professional development, and physician wellness as well. And I have been fortunate to hear her talk on many of those topics as well. So without further ado, Dr. Nguyen, the floor is yours, and look forward to the talk.
Dr. Singh, thank you for that introduction, and thank you again for the invitation. Let me see if I can do this share correctly here. Okay, I believe you're all seeing my screen.
Yeah, perfect.
And as I mentioned, this is functional dyspepsia and gastroparesis, my favorite talk. And this art, actually, you'll see behind me, and this is a piece of art that I had commissioned, which really signifies kind of my passion. So that brain-gut interconnection and the abstract nature of it, the ambiguity part really signifies sort of what we deal with, because there's no black and white. Our patients don't fit into boxes, and we don't have FDA-approved therapies to take care of our patients, but they're there, and we still have to take care of them. So this piece of art is really a culmination of my entire career. So my goal for today is to define and differentiate idiopathic gastroparesis and functional dyspepsia. And I understand there is diabetic gastroparesis, but I'm really going to spend most of the time on idiopathic gastroparesis today. Examine the burden of disease and functional dyspepsia and gastroparesis. And the reason I'm doing that is that oftentimes you think functional, you kind of put that in quotes, and you think, oh, there's nothing wrong with you, you're fine, go live your life, you're too stressed. And I want to show how much these diseases burden the healthcare system as well as the patient, their families, and the community, and propose really a patient-centered framework for the diagnosis and management of idiopathic gastroparesis and functional dyspepsia. And I'm going to start with the question that's being raised frequently is, are they the same or are they different? And I'll start with the punchline is that I think that they're distinct disorders with significant overlap. And patients, and I'll show you data on this, that patients can flip-flop from one to the other or have an overlap. So, we think about irritable bowel, there's IBS diarrhea, IBS constipation, and then IBS mix. So the functional dyspepsia, idiopathic gastroparesis is kind of similar to that. So patients can kind of flip in and out. And the true functional dyspepsia, I think, is that the patients with the epigastric pain syndrome with normal gastric emptying, and the idiopathic gastroparesis patients are the ones without significant abdominal pain, more nausea and vomiting, predominant with severely delayed gastric emptying, and majority are somewhere in the middle. And I think the challenge here is when you think about the diagnoses and the definition. So you see functional dyspepsia, the definition is bothersome, postprandial fullness, early satiety, epigastric pain, or burning in the absence of structural abnormalities. And there's two subtypes. There's a postprandial distress where there's meal-related and the epigastric pain syndrome, where there's pain and burning that may or may not be related to, that's not related to meal. And nausea and vomiting may or may not be present. Gastroparesis is defined by the presence of delayed emptying. And then if you look at the symptoms that are present in patients with gastroparesis, nausea is the most common, followed by vomiting, but abdominal pain is also there. So you see, if you just look at the symptoms, there's a lot of overlap. And the reality of it is there's only so many symptoms that the gut can manifest. So of course, there will be significant overlap there, especially if the diagnoses are symptom-based. And so what are some of the mechanisms or the pathophysiology of some of these symptoms? And in the diagram, you see the picture of the brain and the stomach. And with the stomach, you have the fundus that relaxes or accommodates after a meal. And if you have impaired accommodation, that can lead to symptoms. And I think of that as like diastolic dysfunction for the heart. So the symptoms are fullness, early satiety, and weight loss. You can have antral hypomotility, so the contractions are impaired. And that can lead to delayed gastric emptying, or what I call systolic dysfunction. And again, similar symptoms of fullness, abdominal pain, nausea, vomiting, spasming of the pylorus. So again, analogies to the heart, like outlet obstruction, delaying gastric emptying. There could be duodenal dysmotility or hypercontractility, where you have impaired coordination. And that again can lead to like obstructive like symptoms. And then you've got the mucosa. Increasingly, we're seeing duodenal and gastric mucosal dysregulation. So there's increased eosinophils, mast cells in both functional dyspepsia and gastroparesis, inflammation with H. pylori, post-inflammatory, visceral afferent abnormalities. So there's visceral hypersensitivity, and then there's dysrhythmias. And these symptoms can lead to learned behavior, psychological stresses, and factors that lead into this vicious cycle. And the reason there's a lot of room for debate, if you think about the causes of gastroparesis, idiopathic and diabetic are the most common, followed by post-surgical and neurologic or Parkinson's. When you take the group of patients with idiopathic gastroparesis, and this was a study that was done by the Gastroparesis Consortium, looking at those that met Rome criteria for functional dyspepsia, and this is a 2011 study, so we used Rome 3 criteria back then, and 86% of patients also met criteria for functional dyspepsia, and not surprisingly, the most common type was the postprandial distress subtype. The other thing that you to note here is that over 60% also had concomitant irritable bowel syndrome. So if you treat someone with gastroparesis and you're purely treating the stomach but ignoring the lower gut, you're doing patient disservice, and it may not be impacting their quality of life or symptoms. The other challenge with gastroparesis is that the gastric emptying study is unstable. And this was, again, the Gastroparesis Consortium study, where they had gastric emptying scintigraphy at baseline when they entered the registry, and they repeated the gastric emptying 48 weeks later, or about a year later. And they looked at the patients who had delayed emptying at the beginning, so the gastroparesis patients, and found that 42% a year later switched over to normal emptying, and 37% of patients who had normal emptying at the beginning had delayed emptying 48 weeks later. And you would think maybe that this is associated with a change in their symptoms. And you see here that there's really no correlation with their symptoms here and the gastric emptying. And this is just two different ways of showing that data. So the changes in gastric emptying, or the switching of diagnoses, was not associated with any changes in the symptoms or symptom severity. So we've talked about functional dyspepsia and gastroparesis. What's the burden of this disease, again, on the system as well as the individual? So let's talk about how prevalent this is. This is a Rome survey. There's an internet survey and a household survey. And this was all the DGBIs, or all the functional GI disorders. And using the internet survey, 42% of patients met one of the Rome criteria for a functional dyspepsia, for a functional GI disorder. So this is why I say that if you go into the field of DGBI or motility, you will always have a job. Whether you go into this field or not, you will come across patients with DGBI. But looking at functional, at the specific Rome diagnoses, you can see that functional dyspepsia is the most common, that at a little bit over 7% in terms of worldwide prevalence there. And then they use the same data to look at sort of prevalence of gastroparesis and gastroparesis-like symptoms. And so for the gastroparesis-like symptoms, they looked at patients who had nausea or vomiting more than one time a week and met the Rome criteria for postprandial distress symptoms. And what they found was worldwide, there was an overall prevalence of 0.8%. And then amongst those with diabetes, it was higher at 1.3%. When you look at kind of other studies looking at the prevalence of gastroparesis in the US, it ranges from 0.16 to 1.8. So we don't know the true prevalence of gastroparesis. And in part, it's because the diagnosis of gastroparesis requires a gastric emptying test of some type. So it's hard to do population-wide studies where you need, a diagnostic test for that. But here are some disturbing trends in gastroparesis, right? So this in the upper left, you have the hospitalizations, and from 2000, you see the steep rise in hospitalizations for gastroparesis, and this is looking at the NIS database. This is on the upper right, you're looking at imaging. These are advanced imaging like CT, MRI of patients who come into the emergency department for different symptoms. And for abdominal pain, you see this increase in the utilization of advanced imaging. And the bottom left, what you see here are therapies that we're using for patients with gastroparesis. And you see that there's an increase in opiates and a decrease in prokinetics, despite the fact that we know patients with gastroparesis should not be treated with opiates. And you see that there is decreased survival. So overall, patients with gastroparesis have increased hospitalizations, increasing use of advanced imaging, increased use of opiates, and increased mortality. And then when you look at ED utilization, gastroparesis-related ED visits have increased over the last 7 years. And the green arrow is gastroparesis, and the blue arrow is functional dyspepsia. It's increasing, but not at the same rate as gastroparesis. Why this is more in the South, not sure, but if you look at the diabetes kind of belt and prevalence, there is more diabetes and diabetes-related complications in the South than other areas of the US. And then what happens to patients when they're admitted? They get readmitted. So if you look at the 30-day readmission and the 90-day readmission, it's high. Over a quarter of patients who are admitted with gastroparesis are readmitted within 30 days. And there's significant fragmentation of care, meaning that they get discharged from one hospital and go to another hospital. And when they go to that second hospital, the cost of that readmission is even higher. And likely there's a lot of kind of repeating of the testing that's done. And when you look at, this is a study looking at wireless capsule motility in terms of, what are predictors of poor outcomes. And these are patients that we studied at baseline, did a wireless capsule motility study on. Based on those results, we treated them based on whatever the PI thought was appropriate, and then 6 months later followed up. And one of the things that we found that was interesting is that patients who had delayed emptying and met Rome criteria for functional dyspepsia had worse symptoms, so more severe symptoms, and poor quality of life at 6-month follow-up. And then there's also the stigma that the patients experience. So this is a study on the left about stigma in IBS, comparing IBS to inflammatory bowel disease, and whether it's from friends, family, healthcare professionals, spouse, coworkers, or employers, patients with IBS experience more stigma than patients with inflammatory bowel disease. And you can see here, a lot of it does come from healthcare professionals. So we have to be really careful about the language that we use with patients, how we talk about them to each other, and when they're there. And this is a study that I collaborated with Tiffany Taft on, who's a GI psychologist, on looking at stigma in gastroparesis. And these were semi-structured qualitative interviews. And 80% of the patients that were interviewed reported some type of stigma, and it's predominantly perceived, experienced, inactive, and internalized. And the major themes are coming from the medical providers, interpersonal relationships, disclosure, feeling invisible, blaming, self-blame, blaming others, getting unsolicited advice. Like, if you ate this, you'd feel better. Maybe you did something and that's why you feel that way. And so again, the burden is high on the system, high on the patients. So this year, there's been lots of activity in the gastroparesis world. In the red journal, you'll see the ACG guidelines here on the left. And then on the right is AGA, is from CGH, and more of a best practices. And there's a lot of similarities, but there are differences also. And part of it has to do with the methodology used to come up with these documents. The ACG guidelines use, PICO format, grade methodology, review of the literature. The CGH paper reviewed the literature, but it was really best practices based on expert opinion. So there's opinion on the CGH paper. The ACG guidelines was purely based on grade and level evidence. And the CGH paper also was really focusing on patients who are refractory. And the definition of refractory was that, you excluded medications that could delay gastric emptying. So opiates, we all think about, but also now think about the weight loss medications and diabetes medications, the GLP the therapies, and then those who failed a small particle diet, and I'll go into that diet a little bit later, and then metoclopramide. So those who failed that first line therapy, then what Brian Lacey and group looked at was looking at the predominant symptoms, so nausea and vomiting versus pain predominance, and then the severity, mild, moderate, versus severe. The ACG guidelines, again, like I said, looked at the grade of the evidence and recommended dietary modifications, pharmacologic therapies, nutrition support, followed by non-pharmacologic. And my approach really is a blend of both of these kind of the guidelines and the best practices. And in part, the challenge of coming up with a guideline that's evidence-based is when you don't have FDA-approved therapies. And I would say, of all the projects I've worked on, helping to co-author the ACG guidelines was probably one of the most challenging things that I've done. So what is a small particle diet? So oftentimes we think of the gastroparesis diet, we think of low fat, low fiber, eat, small, frequent meals. And if you think about that diet, it's basically all carbohydrates, not very healthy diet. And the small particle diet, there's no restrictions on what types of foods you can eat, but they have to be just easily smashed with a fork. So I tell patients, like the fork rule, if you can break it up with a fork, it's digestible. And so the table there are examples of how you can take a poorly digestible food and make it easily digestible. So instead of eating whole almonds, you can have almond butter, or instead of eating a whole avocado, mashed avocados. And by comparing the small particle versus the standard gastroparesis diet, well, not comparing the two head to head, but looking at the patients on the small particle diet before and after, you see that with the small particle diet, there is a decrease in nausea, vomiting, fullness, bloating, But in the standard gastroparesis diet, there isn't an improvement in symptoms. So I've moved away from telling patients to eat low fat, low fiber. I tell them to eat low fat, but small particles, so that they are able to get the fiber in their diet. Because low fiber can also lead to issues with constipation. And I'll show you later how much of an impact constipation can have on symptoms in patients with gastroparesis. And you know, working with a dietitian and endocrinologist is important in patients with diabetic gastroparesis, because this is a study it's showing that glycemic control improves gastric emptying symptoms and the gastric emptying patients with diabetic gastroparesis. So this is a study using a CGM and an insulin pump to tightly control the glucose in patients with diabetic gastroparesis without any other therapy. So this is a pilot study to look at the safety and feasibility. And you can see there with the gastroparesis cardinal symptom index and the different subscores, there's an improvement in symptoms. So in patients with diabetes, improving their glycemic control alone can help. So then, you know, both guidelines talk about prokinetics. So what's the story between prokinetics? Why is there this decreasing utilization? And just to start out, what are the types of prokinetics out there that are available in the US? You have the prokinetics that we think about are traditionally prokinetics and antiemetic combinations, so like metoclopramide, domperidone, prucalopride, tegaseride. They all have, you know, prokinetic and antiemetic properties. Purely prokinetics, they just increase motility but have no antiemetic effects, are the motilin agonists like azithromycin, erythromycin, and the acetylcholine receptor agonists like prednistigmine, neostigmine, bethanechol. And you see the two studies below are two different meta-analyses looking at prokinetics and whether or not acceleration of gastric emptying leads to improvement in symptoms. And in the study on the left, you see here that there's no correlation there. And on the right and the top, again, you see similarly that there is no correlation between improvement in gastric emptying and symptoms. But in the bottom, when they took out only the studies that had an optimized gastric emptying study, you do see an improvement. So, you know, when you diagnose gastroparesis, you want to make sure that it was an appropriate optimized gastric emptying study. What does that mean? It's a solid meal, and the gastric emptying was measured for more than 3 hours, preferably 4 hours, and it has to be a standardized meal. So if someone comes with an oatmeal gastric emptying test that says it's delayed, it's not an optimized test. If someone comes with a liquid gastric emptying, it's not an optimized test. So if you can't do an optimized test, don't even bother doing it. It's a waste of time, money, and it's radiation exposure. And the only FDA-approved therapy is metoclopramide. And I'm still older than metoclopramide, but not by much. So it was FDA approved in 1979, and it remains the only drug approved for gastroparesis. It's actually diabetic gastroparesis. And if it came onto the market today, the data would not be appropriate for FDA approval. But then, it's tainted by this black box warning. And since 2009, you see a decrease in prescriptions of metoclopramide because, physicians and patients are worried about the side effects of metoclopramide with the tardive dyskinesia. So what about prucalopride? It's a 5-HT4 agonist. It is FDA approved in the US for constipation. And this is a study by Jan Tok's team where they looked at patients with idiopathic gastroparesis and prucalopride 2 milligrams per day. And what you see is that there's a decrease in vomiting, early satiety, bloating, and reflux symptoms. And there's an acceleration in the gastric emptying test. And so, do I use prucalopride? I can't for patients with purely gastroparesis, but if they have constipation, then you can. And so this is a study here looking at the wireless capsule motility study or SMART pill in patients with gastroparesis symptoms or gastroparesis-like symptoms. And what we found here was that a third of the patients had delayed colonic transit, and about half of patients had delayed colonic transit or gastric emptying test. So patients with delayed emptying often will have delayed colonic transit, so then you can prescribe it for the constipation and impact both symptoms. And here is another study from the Gastroparesis Consortium, and they looked specifically at constipation severity and gastroparesis symptom severity, and they found that patients with more severe constipation had more severe gastroparesis symptoms. The question that they didn't answer in the studies whether or not treating the constipation helps with improving the gastroparesis symptoms. And my experience, kind of just a gestalt of my experience with my patients, is that it does help. So in patients with gastroparesis, the therapies may be limited for the stomach, but if you can make an impact in their bowel symptoms, then you can impact their overall well-being and quality of life. Then looking at antiemetics, which is sort of the next recommendation there, and the caveat here with the antiemetic recommendations is none of these therapies have been systematically studied in gastroparesis except for aprepitant, and I'll show you that data later. Well, I take it back. Domperidone has been studied, but it's not readily available here in the U.S., but you can get it through an IND. And the way I think about using these antiemetics is that there are different classes and different mechanism of actions. So oftentimes we have to augment therapies and layer on the medications so that when you choose therapies, let's say you do use metoclopramide and you get a partial response, if you want to add something else, you would not add another medication that's a dopamine 2 antagonist. You may want to choose something that is a 5-HT3 antagonist or H1 antagonist. So as you layer, think about the mechanism of action and how they can be complementary. And so this is a study on a aprepitant where patients with nausea with gastroparesis and gastroparesis-like symptoms were given either aprepitant 125 milligrams a day versus placebo for 4 weeks. And the study did not meet the primary endpoint in terms of nausea, but all the secondary endpoints in terms of the GCSI and pain, you do see an improvement. So no difference with the primary endpoint, but you do see some promising results with the secondary endpoints. And then there's the neuromodulators, which are commonly used. And if you look at the AGA paper, the patients with pain predominant gastroparesis, the recommendation is to use a neuromodulator, and they're the tricyclic antidepressants, SSRIs, SNRIs, tetracyclines, and delta ligands. And there are different effects on the gut. So for example, the tricyclics will decrease motility. The SSRIs may cause more diarrhea. And so the way you choose is really based on what symptoms you're trying to affect, and then look at the side effect profile to see if you can either minimize the side effects or leverage the side effects. So for example, if someone has gastroparesis and IBS diarrhea, I may choose a tricyclic. However, when you look at the ACG guidelines, the recommendation is against using central neuromodulators. So, and it's with a moderate level of evidence, and it was a strong recommendation. And I'll show you the data as to why that's the recommendation. Neuromodulators have also been used for nausea. And again, you've got the tricyclics, the tetracyclics, and the atypicals. But again, if you look at the published data as to how and why we're using this, the data is very limited. Case reports, case series, and the only RCTs are for other disorders. So typically chemotherapy-induced nausea and vomiting, or postoperative nausea and vomiting, and we're just borrowing from them. So this is the study that led to the recommendation against using nortriptyline, or central neuromodulators. So this study looked at nortriptyline and idiopathic gastroparesis. All patients started with 10 milligrams and were titrated up to 75 milligrams versus placebo. And you can see here at the end of the study, which was 15 weeks, there were no differences in any of the gastroparesis symptoms or the total GCSI. However, when we did subgroup analysis, the 10 milligram dose seemed to improve nausea and abdominal pain. And remember, tricyclics have the added effect of the anticholinergic side effects, which will further delay gastric emptying, worsen constipation. And I already told you earlier that constipation is common in patients with gastroparesis. So it may be that there's a subgroup of patients who might benefit from low dose tricyclics, but beware of those who have constipation. And then there's buspirone, which is a study. This was more in patients with functional dyspepsia, and they looked at, gastroparesis or dyspeptic type symptoms and gastric emptying in these patients, and found that buspirone at a dose of 15 milligrams 3 times a day improved symptoms of fullness, bloating, belching, and nausea. And there was also an acceleration of the gastric emptying. So how do I choose the right neuromodulator? And my recommendation to everybody is start by becoming comfortable with 1 or 2 classes. So in the tricyclics, pick one and be comfortable with that, or an SSRI and NRI. So once you become comfortable with one class, then you can start adding in other classes. And then when you talk to patients about it, you want to explain the rationale that why you're using it as a neuromodulator, not an antidepressant, because then there's that mistrust there. Just lots of medications have dual purposes, right? So aspirin is used for pain and headaches, but we also use aspirin for cardiovascular effects. So there are plenty of examples of medications being used for dual purposes. Same thing with the neuromodulators. And I explain this to patients all the time. Leverage the side effects for benefits. So if a patient has insomnia also, then I'll choose a medication that is sedating. If they have, like I said, if they have diarrhea, I choose something that is anticholinergic. Start low and go slow, and trying to minimize the side effects and set expectations that it can take 6 to 8 weeks to see improvements. Otherwise, patients will take it for a few days, they don't feel better, and they stop it. And again, augmentation is often necessary. And similar to what I said with the antiemetics, choose medications with different mechanisms of action. So, so I showed you a list of antiemetics and neuromodulators. How do these fare? So obviously there's no RCT comparing all these. We did a survey in our clinic looking at patients with chronic nausea, and we gave them a list of all the different therapies that you could think of for nausea, and they rated it on a scale of 0 to 5 in terms of efficacy. And overall, the mean efficacy of the antiemetics is 1.73, so not great. And what rose to the top was marijuana, ondansetron, and promethazine. And neuromodulators seem to have the worst response. And patients with more severe nausea tended to do better with marijuana, diphenhydramine, and metoclopramide, or at least that's the perception there. So these are all patient reported in their perceptions of their experiences. And so when patients were surveyed about kind of how they feel about all the treatment options, and not surprisingly, majority of patients were either dissatisfied in blue, somewhat dissatisfied in orange, or neutral. And you have about 20% who were somewhat satisfied or satisfied, or 4% were truly satisfied with their therapies. So despite that list, the patients are not satisfied with their therapies. And this was a study by Brian Lacey, and this kind of gives you the impact of this on patients. So this was a survey by Standard Gamble. So patients are said to just make believe, pretend there's a pill that's available to treat your gastroparesis, and if you take it, it could cure you of all your symptoms. However, there's a chance that you could die if you take this. And what would you want to know about the pill, and what would you do? And what they found was that the patients accepted an average risk of 13.4% of sudden death. So all these patients that said that, I will accept about 13% chance of dying for an 87% chance of cure. So their risk tolerance is quite high. These are desperate patients to get better. They would rather die, or they would risk dying to feel better or to have a cure. So keep that in mind. And so when none of the therapies work, and they likely will not, given what you saw on the surveys, they're non-pharmacologic therapies. And this, again, is based on the ACG guidelines. But I'm going to talk mostly about the gastric electrical stimulation and the GPOM. And GPOM is kind of the new kid, new kid on the block that everybody wants to be friends with. And all the early studies were single center, open label. And this truly is a study that I've become more of a believer in GPOM. And this was done in Europe and was hot off the press this year. And they compared GPOM versus sham endoscopy. And the study had to be terminated early because when they did their interim analysis, there was such a significant improvement in the GPOM group that the safety board said, you can't continue the sham arm. And overall, you found that, so this is the overall group that GPOM helped, over 70% of patients with gastroparesis, and this is a breakdown in terms of diabetic, post-surgical, and idiopathic gastroparesis. And you can see here the green line are the patients who underwent GPOM, the decrease in their gastroparesis symptoms at 3 and 6 months. And then the blue are the patients who had sham, so there was not a significant decrease. And then when the patients who got sham crossed over to GPOM, you can see that their symptoms improved similarly to the patients who had the initial GPOM. And then gastric electrical stimulation has been around since 2004. It's under humanitarian exemption study. And again, the studies have been mixed. This is a French study where they implanted everybody, and then they left them off, and then they randomized them to on or off, and then they crossed over. And the vomiting score is a little bit different than what we're used to seeing. So the higher vomiting score is good, lower vomiting score is bad, based on that, a score of 4 means that they had no vomiting, and a score of 0 means that they had several vomiting episodes per week. And you see here that there was an improvement in vomiting scores. You also see an improvement in nausea and the quality of the appetite, but does not improve pain. So going back to the Lacey paper, I definitely look at the predominant symptoms. If someone has pain-predominant gastroparesis, I do not recommend a gastric stimulator because it does not help with those symptoms. And again, another study from the Gastroparesis Consortium, they looked at predictors of symptom improvement. So who are the patients who improve over the time? So the positive predictors for improvement are older age at onset, an infectious prodrome, so the post-infectious gastroparesis, they tend to get better on their own, irrespective of what they do. Antidepressant use, a higher GCSI score. I think that's more of a regression to the mean kind of thing. If you start out with severe symptoms, you're more likely to decrease. And if you have the more severely delayed gastric emptying. And the thought there is that the patients who have more severely delayed gastric emptying are more likely the true gastroparesis, as opposed to that gastroparesis functional dyspepsia overlap. Negative predictors are smoking, severe abdominal pain, depression, use of neuromodulator, anxiolytics, or severe GERD. And then I'm going to go quickly through we talk about gastroparesis, but patients often need a team approach in gastroparesis. And I'm going to highlight some of the ones in the light blue as a rationale to why. And why there's a need for, behavioral and pain specialists. And so, as you know, there are different psychological therapies, and cognitive behavioral therapies, the most common, where patients have their symptoms, but then the negative thoughts and emotions can lead to kind of exacerbation of their symptoms and lead to this vicious cycle. So cognitive behavioral therapy can kind of help break that cycle. And this is a study looking at functional GI disorders in patients with or without other comorbidities, including psychologic as well as extraintestinal, like chronic pelvic pain, interstitial cystitis, migraine, etc. And the main thing here is that patients with DGBIs who have any of these comorbidities have lower quality of life scores and more severe GI symptoms across the board. And we saw this in our patient population. So the patients with gastroparesis tended to have more migraines. So over a third of patients in our gastroparesis cohort also had migraine. In this study, we looked at like pain in patients coming in with abdominal pain symptoms, and those who had widespread pain in multiple areas had more severe GI symptoms, greater pain interference, anxiety, depression, and anger. And the thought is that there's some overlapping pathophysiology with autonomic dysregulation being one. And I'm going to move quickly through this because I know we're almost out of time. Is that in our patients, we do see that there's autonomic dysregulation, not necessarily autonomic failure, but kind of dysregulation of the autonomic signaling that's associated with delayed emptying and severity of symptoms. And with this overlap, it prompted us to think about, okay, can we modify the vagus nerve or stimulate the vagus nerve, use a therapy that's FDA approved now for migraines and cluster? And this is a study using cervical vagus nerve stimulation. So there are branches of the vagus nerve that crosses the carotid. And in this pilot study, we found that 40% of patients who underwent stimulation of the vagus nerve peripherally had improvement with their gastroparesis symptoms. And this is a study that Andres Gottfried presented at DDW, was that we also saw that there was a decrease in the pro-inflammatory cytokines in the patients, especially those who had improvement in their symptoms. And then looking at sleep, disordered sleep is associated with dysregulation of the autonomic nervous system, over almost 70% of patients with gastroparesis report some sleep disturbances. And just on the right side are patients who have disordered sleep, some of the physiologic abnormalities you can see in the digestive system. So again, this vicious cycle of altered physiology leading to worsened symptoms and then worse sleep. And then this is a study that came out of our pain group looking at disordered sleep and opiate use, and that disordered sleep was associated with increased need for opiates, and that 1 hour increase in average nightly sleep led to decrease of opiate misuse by 20%. And then rheumatologists, neurologists, if you haven't diagnosed someone with hypermobility or EDS, it means that you're not looking. And in a study where they just surveyed patients in the waiting room of general GI practice, they found that a third of patients in the waiting room had evidence of hypermobility coming in for various GI complaints. And the most common were IBS, functional dyspepsia, heartburn. So in the functional DGBI world, patients who had functional GI disorders and EDS tended to be younger, female, with higher autonomic scores, more chronic pain, decreased quality of life. So I look all the time, and I can tell you that I diagnose a new patient at least once a week in my clinic. And then I'm going to finish up with the autoimmune gastrointestinal dysmotility. This is the overlap of kind of where the autonomic neurologists, immunologists, and gastroenterologists come in. And these are patients with GI dysmotility with lots of extraintestinal symptoms like autonomic symptoms, dizziness, headache, bladder symptoms. They may have family history of autoimmunity. And when you test them for autoantibodies, you may find one of these autoantibodies positive. And these patients may benefit from immunotherapy with IVIG or methylprednisolone. And here you see that, and there's no standardized, study or protocol. These are all, case series, but the therapies can lead to about improvement in about 74% of patients. And so I finish with when you think about the patient with gastroparesis, you think about the patient, their family, the supporting not only the patient, but the families, and you need kind of all these folks. And oftentimes as the gastroenterologist, you're looked at to kind of, navigate all these interactions. And so my approach, I always elicit and prioritize patients' goals, irrespective of their symptoms. And you'll be surprised in terms of, how many patients have the same disease, but they have different priorities. I review their comorbidities. I look at the timeline. Those with acute onset are more likely to have either post-infectious or autoimmune. Not all abdominal pain is visceral. Look for abdominal wall pain. And more importantly, breathe. There's a lot. You need to breathe, help the patients breathe. And again, make a positive symptom-based diagnosis, especially in functional dyspepsia. And one of the things that I've learned over the years that I'm very careful with diagnosing gastroparesis, because I think, someone who has 15% retention at 4 hours and nausea and vomiting, I'm very careful about calling it gastroparesis, because that diagnosis, that label goes with them no matter what. And even when I put it in the chart that this patient does not have gastroparesis and they go to the ER, the first thing I see is patient with gastroparesis. No matter the red, the bold, the underline, the highlight, everywhere in the chart I put does not have gastroparesis, it's there. Assess and treat comorbid conditions. Choose therapies based on the predominant symptoms. When combining therapies, choose medications with different mechanisms of action. And the multidisciplinary approach is really key, especially in patients with moderate to severe symptoms. And with that, I'll end, and I'll send you, this is my kind of my diagram of how I start with just the dyspeptic patients, mostly for the fellows, but I will send that to you so that you have for later. And that's it.
Thank you so much, Linda. This was an excellent talk, and I'll open it up for any questions.
Can I ask a question? I'm one of the first years. That was extremely helpful. We actually have a couple patients on service right now with severe gastroparesis that we have been struggling immensely for. So I was like taking a lot of notes. But one of my questions is for TCAs and other neuromodulators, a lot of the patients with gastroparesis also have like small bowel dysmotility or severe constipation. And I've been nervous to start one given the anticholinergic effects that you kind of commented on. If they didn't tolerate motegrity, which is kind of what we started with, which TCA do you like to choose? And like kind of which one do you have the best experience with?